And so it is with an honor and a privilege that I introduce to some Surani hair Kwan. Give her some warm applause.
All right, is my mic on? Good morning, everybody. Thanks for being here. This is the culmination of a pretty long journey that started many, many years ago. I tell people, always wanted to be a nurse practitioner. I actually decided that when I was around 12. My mom and I can't quite remember the nurse practitioner that took care of me, that started me on this journey. But very quickly through my school career, it was clear to me that becoming doctorally prepared was the ultimate for whatever career I decided to do. So at the time I graduated from high school, there was a group of 3 of us that made a pact with each other that we would all be doctors. And so one by one, they have become doctors, and I am the last of the group of 3 to finally get it done. So I know that they're here with me, Jenny and Leslie. One became a vet, one is a professor of history, and here I am. So I want to share a little bit about who I am so you understand where I come from. So of course, none of us could be here without the people that support us, our family and our friends. And this is just a snapshot of the crazy family that I have. So my husband and I call ourselves Chindian, Chinese Indian. We have Indian from North Punjab in our family, and we also have, on my mom's side, people from New York, upstate New York, and then of course on my husband's side from China and Hong Kong. And then my daughter's father was actually French American. So we have a little bit of everything in our family, and it's pretty wonderful mash. So these pictures are just an example of what I live every single day of my life. I've got a lot going on outside of school, and my work life is very challenging, but very engaging and fulfilling for me. So I wanted to start with my story of who my family is and where we all come from. Nothing would be complete without sharing the story of my animal family. I have on your far left is my grand dog, and then our dog, the German Shepherd, and then my daughter's dog, my second grand dog, love my dogs. So this is who keeps me laughing. Sometimes things get very hectic in life, and we have a lot of crazy things that we all deal with on a regular basis, and the dogs, I think, center us. They actually keep us in a place where we can manage to do reality on a regular basis. So why mentoring? Why did that come up for me? And I think for me it was the hike up to North Dome, or well, actually this is Half Dome, but North Dome was what my husband and I did because they closed it. But the hike up to North Dome or Half Dome is treacherous and filled with all kinds of very frightening options. Falling off the edge certainly would kill you. You would be dead in an instant. Now, I'm not suggesting that work or life taking a wrong direction is going to necessarily kill you, but it is very difficult to make our way through life's choices without having support. And the mentors that I've had in my career have helped me get to this place. My doctoral program, my nurse practitioner program, my children, my family, all of the things I do were because I've had support and mentoring my whole life. And for me, I feel that mentoring is something that helps people be successful in the long run. So this was one of the reasons why I thought that mentoring would be a great focus for the work that I'm going to share with you today. The guardrails that you see here in this picture are your mentors. You're in the middle, hiking up that very steep trail. And the reason you don't fall off is because of those guardrails. Those guardrails are our mentors, whoever they may be in your life. So I want to start with my first recognition today. This is my committee chair. You've all met Dr. Paulina Van. Amazing woman. She is one of the most intelligent people I've met, and I am completely in awe with her ideas, the way she sees the world, the things that she's brought into my life in the past 2 years. When I first met Dr. Van, I was at a graduation ceremony for Samuel Merritt for the RN to BSN program. She's the director of that program. And I had come as a representative of Sutter, and I was sitting in the audience because I had actually spoken with this group in their semester. So I came to celebrate with them in their first graduation, and it was a wonderful experience. And Dr. Van came up to me and introduced herself to me and said, "I'm going to be your committee chair." And I was like, "Oh my God, I'm not even in the program." Yes, you will be my committee chair. So I'd like to thank you, Paulina, very much for everything you've done. We have flowers to give you today. My husband is falling down on the job here. Yes, thank you very much. A small token, very small token of my appreciation. I would be remiss if I did not point out the woman in the picture here with Dr. Van. This is Dr. Afaf Malias. She is a famous theorist, nursing theorist, who happened to be the committee chair of Dr. Van at UC San Francisco back in the day. So I kind of like the transition, right? The transition of committee chair to committee chair, and how we have now 2 generations going. So it's pretty special to me that I had the opportunity to meet Dr. Malias, and I used her transitions theory, which I'll share with you later. My second recognition today is my practice mentor, Dr. Anna Kiger. Unfortunately, could not be here today, but she's going to watch the video, so she'll see this. Anna Kiger is a force of nature. She came into Sutter Health as our very first chief nursing officer. Sutter had never had a nurse leader before Anna Kiger. And she came with this amazing breadth of experience in healthcare, and right away knew that she wanted to hire somebody who had an advanced practice degree to help support her in the nursing clinical roles in Sutter Health. And she came and found me. So when I met her, I was very excited to meet the first nursing executive for Sutter Health, and really had no expectations other than introducing myself and thanking her for finally having a nurse leader in the organization. But she is an amazingly supportive person. She came to me with a proposition, a request for me to consider all of the different things that she was looking for. And when she got done, I've kind of laughed at her, and I said, "Well, it kind of sounds like you're looking for somebody like me." Because in fact, I think you actually looked at my CV when you built that entire job description. And she laughed, and she says, "As a matter of fact, I'd wonder if you would actually apply for the job that I now have with Sutter Health." So Anna Kiger is my second recognition. Unfortunately, could not be with us here today, but she says she's in the back of the room in spirit with me. So I wanted to share some pictures of her with you today as well. So let's talk about the problem. What is the problem? The problem in healthcare is that we don't have enough people to take care of all of the people that are going to need care. And why is that? What is happening in our healthcare fields that brings us this problem? I would suggest that, like this bomb waiting to explode, we have burnout. Burnout is what's happening in the healthcare field today. It's really not something that many of us see or even really talk about, but it is definitely something that is affecting all of us and will affect generations to come following us. So I wanted to focus on this particular problem because it was brought to my attention by one of our vice presidents of Sutter Health when we had done a survey of culture. It was done just about 3 years ago, first time we'd ever done something like this. And they actually surveyed everybody, not just the staff that work in the hospitals and the offices, but they surveyed all of the physicians and all of the advanced practice clinicians, the APCs. And he came to me with the results and he said, "Surani, I think you should see this." Now, I don't have an official role as the lead advanced practice clinician in Sutter Health. I just happen to be a nurse practitioner who is in a position in the nursing department, who's got the kind of broad view of the entire organization. And when he shared these results with me, I was shocked, because the survey came in a bullseye, basically. So you could see the different layers of all of the different types of roles that were burned out. So the folks that were on the outside were, I don't know, the EVS workers and the dietitians and things like that. They were on the outside of that burnout curve. And as you came inwards, nursing and physicians were about 50% burnout. So that was not unexpected. We've been reading about it a little bit more in the newspaper here and there. And right in the middle, literally bullseye, were the nurse practitioners. I was shocked. So this shows 61%. Now, only 191 of the nurse practitioners actually took the survey across the organization. We have about 1,000 nurse practitioners and PAs in Sutter Health. This was enough for me to just lose all the blood in my face. And I got that sick feeling in the pit of my stomach. I thought, oh my gosh, what are we doing wrong? This should not be the case. Why are nurse practitioners so burnt out in Sutter Health? Our PA colleagues, not quite as burned out, but they definitely were closer to the bullseye of the nurse practitioners. And our nurse midwives were very close to the middle of that bullseye graph. Very alarming for me. So this was what started me on the journey. I had been, in 2016, already thinking about doing my doctoral degree. It was something, as I said, I had been thinking about since I literally graduated from high school, but it was time now. It was time. And then Dr. Kiger said to me, within a week of me starting with her, about that DNP. When are you going to do that? And I said, you know what, I'm doing it now, and I have an idea for my project. So let's talk just a little bit about what burnout is, because I was having this conversation with my husband about, well, what's burnout? How do we know people are burned out? I mean, how could somebody who's new in their job be burned out? That's ridiculous. You'd have to be in your role for a number of years before you actually would feel burned out. But in fact, what the literature shows is that burnout actually happens anytime. It can happen when you're a kid and you're going back and forth to practices and school, and you're overloaded with so many things to do. This can travel with you all the way through life and affect everything you do. We know that in the workplace, which is what I'm specifically focused on, that a stressful environment in your workplace, no matter what it is, whether you are the executive assistant for a very dynamic nurse leader in the organization, or you are somebody who is overseeing the nursing department and all of the various variety of activities you do, or you're a provider and you're seeing patients, you can't even keep up with the number of people that are on your schedule on a regular basis. Stressful workplaces are the start of it. But then when you have difficult practice on top of that, you start to descend into a pit. And that pit is actually feeling overwhelmed. And at the bottom of that is when you start to feel depressed, or you have no sense of support in your life. And you wonder how you're ever going to get out. And pretty soon, you're looking for opportunities to just escape, because you cannot handle the pressure anymore. This is what burnout is. And it happens to all of us. And burnout is not necessarily something that is long-term. It can happen on a short term and you can come out of it. But in the workplace, when we recognize the fact that we have burnout, we know that we can do something about it. We should. This was the other issue at Sutter Health. When I started looking at the data, this is one of the very first projects that Dr. Kiger gave me. She wanted to know, first of all, how many nurse practitioners and PAs are there in Sutter Health? We had no idea, because nobody really collected that data. So then we wanted to look at, we do all of this data with nursing workforce, right? We know how long nurses have been with the organization. We know when they're coming, they're going. We try to track why they're leaving. But we had no idea what was going on with the advanced practice clinicians. So when we graphed it, this is what I saw. In 2016 to 2017, the baseline turnover is the blue line, and that's a little higher than national average, which runs around 11 to 12%. So that was a little alarming that it's so high. But more alarming was that orange line, that first year of service turnover. Wow. That was amazing because, in fact, nationally, the turnover rate within your first year of a job, if you're an advanced practice clinician, is about 11% or so. It's low. We're almost double that in Sutter Health. So our baseline number nationally, I'm going to make sure I said this correctly, 6 to 8%. Did I say that? 6 to 8% is national turnover for anybody in an advanced practice clinician degree. But when you look at the first year of service, 11% is the national average. So we're sitting at 17.6 going up to 18.4%. Significant. So we knew we had problems. And in some medical groups, some of the medical groups actually had almost 25% turnover. A quarter of their APCs were turning over before they'd even finished 1 year. And I remember when I was gathering participants for this particular survey, one of them left before I could even sign her up for the survey, within 7 months. And she was an amazing nurse practitioner. So let's talk a little bit about the background and how we get here. So we've talked a little bit about the kind of concept of burnout and burnout in the workplace. But here's what the literature is showing us, that there is a thing called transition shock. Kind of crazy. But it's true. And when you think about, no matter what field you're in, if you think about what this feels like as an employee, whatever job you have, and those different stages, you feel a little anxiety and maybe a little insecurity when you start a new job. You're not really sure what to expect. You're not sure where to park. You're not even sure if you can take lunch at noon or should it be 12:30, right? There's all these questions, and that builds up a little bit of anxiety, and you're feeling a little insecure. There may not be anybody in the office willing to talk to you, right? So that builds up a little bit more anxiety. Pretty soon you're trying to be amazing. You're like, you are going to be the best employee no matter what, and you're going to just blow everyone's minds with how awesome you are, and you exhaust yourself because you don't know, should I see 25 patients a day? Should it be 30? Maybe I should do 30 because that would really wow everyone. You're exhausting yourself, right? You spend hours after work charting, you barely eat, and then you fall into bed and you get up the next morning and you go do it all over again. And that cycle perpetuates itself. Then you start to wonder, what about what I'm doing? Am I doing it right? I'm not really sure that I actually understand how to do this job. Maybe I'm missing something. How come those people all go home at 5 o'clock and I'm still here charting? So there's a little bit of a role dissatisfaction that occurs. And then you start to function less optimally than probably you should. Maybe you forget things that you learned in school. Maybe common things like maybe I should have checked that liver function before I put that person on that medication. Basic things that you don't mean to forget, but you forget because there's just so much else going on. You just can't keep track of everything. And then you're pretty much done. You're like, I'm done. I have to leave this job. I am over it. I'm leaving because I cannot handle it anymore. And the grass is always greener in another medical group. They're going to treat me better. They're going to pay me more, which is always at the bottom of the list of why people leave. But I won't feel as overwhelmed because I can't do this job clearly, so I'm out of here. So this is what happens on a regular basis in our organizations. And this is the other thing that many of you have seen in the newspapers, right? You're starting to see more and more in the Chronicle, the Examiner, the Times, the New York Times, Time Magazine. They are talking about burnout, depression, and suicide. And you're thinking, wow, why would a physician commit suicide? Really? Not only really, but in fact, the rate of suicide for our physician colleagues is the highest in the country. So we have a problem. Out of any other job role, our physicians are committing suicide more often than any other role in healthcare. We don't really talk about that. That's amazing, really amazing. And we already don't have enough physicians to take care of all of the people that are going to need care in this country. What we're not looking at is what about everybody else who takes care of the patients, the advanced practice clinicians, right? We don't look at burnout. We don't necessarily measure burnout either. The survey that Sutter did 3 years ago was the first time we'd ever measured burnout in the organization. First time. And that was alarming. So we have some work to do. And The things that we know about burnout is that we have a lot of medical and physiological effects on the body when people are burned out. There are functional issues where your executive brain function is not working anymore. You can't pay attention like you used to. Your memory is shot. You think it's because you're older, but it may not be. You have physical complaints that you really can't quite pin down. I actually have patients who have come in with burnout, and we'll go through everything, and in the end, I'll just talk to them about their job. And then I realize, wow, it's your job that's causing you to feel like this. I've had kids come in with chronic stomach complaints because of anxiety at school. Another classic side effect of being anxious and burnt out. And then also, we know that there have been studies that have shown us that there are alterations in your neural circuits in your brain with long-term burnout, stress, and anxiety. So you have a hard time regulating those negative emotions. So then you see this vicious cycle of it getting worse as you spiral down. And then you have this sense of hopelessness, and you turn to drugs or alcohol or other negative behaviors to help cope with that sense of anxiety and hopelessness. So we can see how it's happening and what happens to the bodies that actually go through burnout. So let's talk about what I did in Sutter Health. The idea was to say, it's here, whether or not we recognize it. I have a feeling that we have burnout in the organization. So how can we control it, right? The only measurement I had was the turnover data, essentially. I knew that we were almost double the national average of advanced practice clinicians leaving their job before a year had passed. So that was my measure. And I thought, well, gosh, let's diffuse the bomb and support these people in their role as they're transitioning into their new careers as nurse practitioners and PAs in the organization. That was the entire goal for this project. I wanted to put formal mentoring into the mix to say, can I increase the resilience of the people that are receiving mentoring and increase the retention of them in the organization? Very simple. And it seemed that we would have to find a better problem to solve because this seemed to be too simple to me to do this. But in fact, it was something that we had never done before in the organization. And what I've found is that I couldn't really find much in the literature either that supported doing something like this to help decrease burnout. So my study question was, will the perception of burnout by that APC actually decrease or remain stable when they have a formal mentor? And also, will I decrease that first year of turnover of our advanced practice clinicians? A couple of ethical issues to think about, not a lot. I wasn't doing any patient contact, so I didn't have to worry about that. I did explain this to the IRB, why I was going to be surveying the advanced practice clinicians. It was something that had never been done before, so they had a lot of questions of like, why the nurse practitioners and PAs? Are there any physicians involved? Why aren't there physicians involved? And then the second big question that I had to resolve was confidentiality. I did have a couple of my participants ask me, well, how am I going to keep the information confidential? And their biggest question, am I going to share this with their medical group leadership? Because they were very worried about that. They're like, I don't know, I don't feel comfortable with them knowing how I feel about my work environment. So I had to assure my participants before I move forward that that was not going to happen. And then also the survey results. We didn't have a very large participant pool. And because of that, it's very easy to see where answers may have come from. So keeping the survey results all pooled together so nobody could actually identify where any of them came from was very important to me. And spreading out who participated was also very useful in that process. So the design was a repeated measures quality improvement. So the repeated measures idea is that I'm going to repeat a questionnaire or a survey on a regular basis for the participants and then gather those results and then compare those to see if we have any significance with the experience that they're having, and then also measure the burnout or the turnover at the end of the year. I did use the transitions, theory of transitions that Dr. F.F. Malias and several of her colleagues developed over a number of years. And what was great about this particular theory was that it really was present in the literature, whether they referred to it or not, because transition shock happens when people go into new roles. And that is clearly what Dr. Malias' theory says, that people will feel this stress and anxiety, and it's really what we do after that that helps them through that transition, right? So the engagement of the person feeling this anxiety and then changing the way they feel about their job is really what the transitions theory talks about. And that was what my entire project was doing. So with methods, I went into looking at how I was going to set this up. So I had Sutter Health to choose from. We are a large Northern California healthcare organization. For those of you not familiar with us, we are separated into two divisions, one in the Bay and one in the Valley, Sacramento Valley area. We extend as far north, actually, as the Santa Rosa, Yuba City areas, and then we go as far south as Turlock and Santa Cruz in the Bay and the Valley. So we're pretty large and obviously concentrated in the Bay Area. We have 5 affiliated medical groups that work with us. So in the state of California, we are not allowed to hire physicians. It's illegal, and there are several rules about that nationally as well. So we contract with our medical groups to take care of the patients that sign up to be Sutter Health patients, whether they're in the hospital or they're coming into the medical offices. And the medical groups then hire their employees. So they have physicians, nurse practitioners, PAs, midwives, et cetera. We do have some nurse practitioners and medical personnel that are hired by the hospitals, but not as many. The majority of them are hired by the medical groups. We have 24 hospitals in that footprint, and we have about 5,000 plus physicians that are Sutter Health physicians that belong to the medical groups. And then we have another 10,000 physicians that are all affiliated with Sutter, but 5,000 that are just medical groups specific to Sutter. And then, as I had said earlier, we have more than 1,000 advanced practice clinicians. And that's a mix of nurse practitioners, PAs, about equal. And then we have a handful of nurse midwives, about 45 or 50 midwives, and we have about 10 nurse anesthetists who actually do anesthesia in the hospitals. The locations for this particular pilot were 3 different locations. One of them was up in Lakeside, in Clear Lake. We have a medical office there as well as a hospital. And the medical office delivers primary care to all of the people that live in that Lake County area. People drive across the lake around the lake to come to get care there. So they pull from that entire area of Lake County. In Santa Rosa, this building, actually, I was looking for a picture after the fire in 2017. The fire literally went through that building like a freight train, but interestingly, the middle didn't burn. Somehow the brick kept the building from burning, but everything, all of that green, is blackened. So it's all been replaced. So the medical office building we have in Santa Rosa that survived the fire was at the other location. And then Sunnyvale, we have several very large medical office buildings, and this is the Sunnyvale location where we also participated with a couple of the folks. We had different practice types. I had initially gone into this with the idea that I would do just primary care because we have a very big gap in our primary care provider pool. We know that people are retiring faster than we can replace them. So there was a desire to focus on primary care, but I found that the specialty areas were also definitely having issues finding anybody to even help them in the offices. So we were hiring a lot of people in the specialty areas. So I decided to include them as well in the pilot. And then urgent care got included as well because we have a number of nurse practitioners and PAs that work in urgent care and in our walk-in clinics with Sutter Health. So I started out with 10 participants. And what I did is I took everybody. I took anybody that was being hired between June and January. So June of 2018 and January 2019. All APCs that got hired that met the qualifications. So they had to have less than 3 years experience, And they had to be working in one of those fields. So nobody that worked in the hospital and nobody worked in the emergency room. I didn't want any of those participants. So we had 10. We started with 10, and then I asked the lead APCs in the medical groups to identify anybody that they would consider a mentor. And when they did that, then I asked them to assign them to the participants. So that was done by the lead APCs. I did not participate in that. And of course, I had other stakeholders that I had to engage, the medical groups and the leadership with the medical groups, the office managers and the supervisors. Often, those managers and supervisors really had no idea what nurse practitioners or PAs did. It's pretty amazing that they work side by side with them. They know what doctors do, but they don't really understand what nurse practitioners and physician assistants do. It's just incredible to me. So I did a lot of education with the offices that were participating in this pilot. And when I recruited, as I said, I was looking for people that had 3 years or less of experience, because the literature actually shows that the feelings of that turnover and burnout, stress, anxiety feeling tends to happen more in the first several years of practice, and then it starts to wane a little after about 3 years. So I said, okay, I'll have 3 years be my cutoff, and we'll see what that population looks like. The mentors were all advanced practice clinicians. There is actually some evidence to say that perhaps doing a like license with a like license is more effective than, say, a disparate physician being mentoring a nurse practitioner. And the reasons for that, based on a couple of the studies I read, were that there is a sense of perhaps self-esteem issues related to somebody being a physician versus a nurse practitioner or a PA, and that may be like an unconscious bias that they may not even be aware of. So that actually deserves a little bit more study in itself. But I decided to just choose advanced practice clinicians to be the mentors in this particular case. We talked a lot about the confidentiality of this particular project, and the idea was that we would increase engagement by having people involved in this pilot. So they would be interested to know what the results were going to be for something like this. So here was the mentoring intervention. We kept it really simple because everybody's different. And as we were talking about this morning, my mom and I were talking about mentoring in education. She was a teacher for 45 years, and mentoring is actually something that they've done in the educational field for many, many years. There's a lot of literature to support the effectiveness of mentoring for new teachers. And it's true that when you have an individual who is assigned to you to be your mentee, what they need may be very different from somebody that you mentored the year before. So mentoring interventions do need to be more unique. They need to be focused on the individual and what that mentee is asking for and needs. And I wanted to keep the amount of time reasonable. So we were going to do this over 9 months. Of course, this was a system project, so it pushed into a year, but I was measuring for 9 months. And I asked initially to kind of set up a relationship that they should meet weekly, just weekly for the first month, and then monthly every 3 months after that. So that's all I was asking for. I wanted them to meet just 8 times for the entire 9 months. And they all felt that that was incredibly reasonable, and they thought for sure that they would probably meet more than that. So the elements of the pilot were really the introductory piece, and then kind of the model of mentoring. What does it mean to be a mentor, and what does it mean to be a mentee? Understanding what it means to be a listener, and then also a guide. And then also roles. So I had a lot of conversations with my mentors because they were asking about clinical mentoring, right? They have these new employees that are coming into the organization. It's like, well, should I show them how to put that IUD in, or should I not? Should I just, be the mentor for questions that they have about being in the medical group? And the answer is no, I don't want you to be the clinical mentor. Yes, absolutely, show them how to do things clinically if that's what you want to do, but the pilot is actually measuring something completely different, something a little bit more subjective, if you will. Clinical is very objective, and can you do it? Yes, no, and we're done. But the formal mentoring that I was looking for was something that was more of a wraparound, more of a relationship building, supportive role that would help the mentee feel that they had somebody to turn to. that they could reach out anytime, day or night, with questions, no matter what those questions were. They would never be judged, whether they were silly or not silly. It didn't matter. That was the role that I was looking for. So I did have those conversations with my mentors that participated in this pilot. So they were very clear what my expectation was. The cost of this project was actually very affordable. The tool that I used to measure the burnout, the survey, was the thing that cost the most money. So the reports were about $200 a piece. I had to buy 5 of those reports for every time I measured. And then every person who took the survey had a licensing fee, which was about $3.50. There was obviously indirect costs that we didn't necessarily capture. The time that it took to take the survey, because people were taking the surveys on their cell phones, probably walking out to their car on their way because I was reminding them to take them, or they could have done it at home. So again, that precious time that we have that I wasn't necessarily capturing the cost of. And then also the time that they had meeting with their mentor, the mentor and mentee meeting. That's also time that's essentially not paid for. So those are costs in people's lives, whether they are directly related to the clinical work or not. There are things that I definitely wanted to at least put out there. So here was the kind of timeline that we started with. We were going to get an informed consent from the participants. We were going to do the baseline survey right at the beginning before they started work. And then I was going to match the mentor and mentee, get them introduced, and send them on their way. The surveys then arrived via email. Everyone felt comfortable with that. Many of them loved the fact that they could just do it on their phone. I think only 2 did the survey on the computer. Everyone did it on their phone otherwise. And we pushed these out on a regular basis. So I had reminders on my calendar to push out the emails with the survey link. And then I had to follow up to make sure that they got those surveys done. And then I was also checking in with them on a random basis to say, hey, just checking in to make sure you've met with your mentor this month or last month, and here are some things you can consider doing. And then finally, we did the data collection. So we tabulated all the burnout scores. The company did that for us. And then our statistician pulled everything together for us. And then I had to collect the turnover data from our recruiting team. So let me tell you about this really cool tool called the Masslike Burnout Inventory, MBI. Christina Masslike and Susan Jackson created this in 1981. It's been around quite a long time. There's a lot of information about burnout in the literature, and there's a lot of surveys that are out there as well. Some are good, some are not so good, but the one that I found consistently showing up as highly reliable was the Masslike Burnout Inventory. So I thought, I'm going to use that one. So I did some research and decided that this was really ideal because they actually have 3 different types of surveys. One is specific for healthcare, specifically nurses and physicians. Couldn't have been more perfect. There really isn't something as perfect as that. And then they also have a survey specific for educators, and they have another survey that is intended for general workers. The interesting thing about Masslike is that they created their survey specifically for people who work with people, so who are in human services. So if you interface with another human being as a regular part of your job, Masslike Burnout Inventory is actually going to be a very good tool to measure burnout in your particular field. So we know burnout is a continuum. Based on all the studies we've done, all of the literature has pointed to the fact that burnout, as I said in the very beginning, you can have burnout and it can ease. It can come back and ease. The problem is burnout that is not resolved and leads to eventual turnover or suicide in the worst case. And so we know that it comes and goes and is in waves. And these human service jobs experience this kind of wave-like feeling in their jobs all the time. So it's normal. The second survey that Masslike has available, which is not necessary to do for burnout, but I thought it would be interesting, is this work-life survey. And what it does is it looks at the kind of other things that are going on in your life, so you can actually perhaps find things that would point to why somebody's having burnout. They ask questions about your workload. They ask questions about kind of your sense of control in your work environment. And they ask about whether anyone's recognizing you for the work that you're doing. Do you get thank you notes? Does anyone ever thank you for the work that you're doing? And that is kind of an interesting thing, because burnout is, am I feeling burned out, 0 through 6, put it on the scale. But in fact, if somebody asks me, do I feel like I'm being recognized at work? And I say, yeah, you know what, no. I'm going to put that as a 6. Nobody's ever recognized me. That actually tells me something. So it was an interesting idea that Masslike came up with to add this secondary survey to all of their testing. So I decided to move forward with that as well. So burnout, essentially, to just remind everybody, is this imbalance of your demands and your resources. And the flip side of that is, if, regardless of how busy your job is, right? If you have a very busy job but you have a ton of resources, you're not going to have burnout. You're going to be successful in your job. So that's kind of the idea of offering a formal mentoring to support a new advanced practice clinician in their job. Crazy job, but if they have the resources to support them, they'll make it through and be successful in the long run. So Masslike is an incredibly valid tool. The idea of EE is the emotional exhaustion. The average reliability score on that is in the high 80s. So if you had a 1.0, that means that all of your participants 100% agree with each other on what that question means. So the emotional exhaustion part of Masslike was very reliable. So that was great to see. Then the depersonalization, you'll see that as DP, and the PA, which is personal accomplishment, those two typically sit in the mid-70s, so 0.7. For reliability. So again, remember 1.0 is super high reliability, 0.775, not too bad, right? Anything that is low would be below that, and so we would consider that poor reliability. And we would do a statistical test called a Crone Box to confirm reliability of the study pilot that I did, so I'll share that with you later. And then the validity of this particular survey is demonstrated with many, many studies that have used Masslike. They've done meta-analysis where they take multiple studies and compare them to each other to say, hey, did they find the similar results with Masslike or not? And they have found that the validity for this particular survey is very high as well. Here's what scoring looks like for our participants. So all of the subsections, every single question looks like this. So this is item 8, I feel burned out from my work. So they would rank it 0 to 6. So they would say every day, I feel burned out every day. And number 0 would be never. So they would rank themselves based on this and submit it. So they had about 22 questions, and they ranked them on this Likert scale, and that was done on the every 3-month basis. So the MBI survey, as we have talked about for medical personnel, does not come up with a single score. I wanted it so bad to be a single score, but it's not. The 3 sections, the emotional exhaustion, the depersonalization, and the personal accomplishment, are very separate from each other, and they should be considered separate as well. So when I look at the Masslike burnout tool for each individual and what they're scoring, I'm actually getting the scores based on these 3 sections. So the emotional exhaustion piece is that sense of feeling overextended or exhausted from your job, your work, your life, whatever. And your depersonalization is kind of feeling like disconnected, like I don't feel connected with anybody at work. I don't care, I don't want to hear about your cat or your dog, I'm just not there. Personal accomplishment has to do with that sense of a competence, like I am a rock star. Oh my gosh, I totally did that, nailed that IUD, I can't believe I did it, I feel so good. That is that sense of personal accomplishment, right? For all of you not in healthcare, sorry. And then, of course, the areas of work-life survey. These are actually pretty interesting. The 6 key domains. It's the workload and control, which I already mentioned, and reward. But it goes on to actually ask about the community that supports you, right? Like my pictures at the very beginning of the presentation. Who is your community that supports you? Your sense of fairness in the world, and also your values. So the work-life survey it's a very interesting wraparound survey to get the sense of how people are feeling. So here are some examples from each section. I just wanted to give you a taste of what each section looks like. So emotional exhaustion, anyone that scores higher, remember it's 0 to 6, anyone that scores higher is going to be more burned out. So I feel emotionally drained from my work. I feel burned out from my work. I feel like I'm working way too hard for my job. Like I feel like at any moment we could probably rate these for our job in a day-to-day basis. And keep in mind, this is just a dip into the 3-month time period for each participant, just to see how they were feeling. So I wasn't measuring them every day. We were just dipping in to say, how's the temperature today, and getting their feedback. The depersonalization, again, higher scores mean that they are more burnt out. So I feel like I treat some patients as if they were impersonal objects. It's kind of scary, huh? You as a patient, having your provider feel like that, right? That would not be good. I would not want that. I've become more callous towards people since I took this job, right? That's also frightening to me, to lose that sense of desire to help people. And I feel patients blame me for some of their problems. Like, who of us has not felt like that, right? My fellow nurse practitioners, right? Sometimes it feels like that. And then you have to question yourself, wait a minute, let's take a step back and say, what is that really all about, right? Is that me, or is that the patient? It's you. So again, depersonalization. And then personal accomplishment, low scores mean that you are more burned out. So I can easily understand how my patients feel about things. Really that personal connection, right? People explain things to me and I feel connected to what they're telling me. I deal very effectively with the problems of my patients. So I feel like I can handle it. I feel like, hey, you come in with anything, I got it. I got you, and I'm going to take care of you. And finally, I feel exhilarated after working closely with my patients. I remember one day, Jen was finishing her shift at the Russian River, and she was like on the ceiling, so excited. It was an amazing day. She had an incredible day. Her charts were done, and she was like a rock star. And I was like, man, she is super high in personal accomplishment today. It's an awesome feeling. It's a great feeling to walk out on a Friday evening with that feeling, right? No matter what job you do. So that's what we're looking for with personal accomplishment. So here's what we did for analysis. Oh, statistics. Repeated measures for every scale, okay? So it's not a single score. Every scale had to be measured. So we used a Freeman Nova. Those of you, anyone know what a Freeman Nova is? Looking at my brother who did his PhD, and Ellen who's a statistics, yeah. So the Freeman Nova is perfect for this particular type of a survey because it can take those repeated measures and compare them together. So our dependent variables were those 3 sections of the Masslike burnout inventory: the emotional exhaustion, the depersonalization, and the personal accomplishment. We did means and standard deviations. So your standard deviation typically should be 50% of what your mean is to be good. And then frequencies and percentages for demographic items. So we did the internal consistency analysis as well with the Crone Box alpha that I was mentioning earlier on those 3 burnout surveys, just to see what we had. And here's a timeline. I know you guys want to see those numbers so bad. We started with 10 people, and you know what? I lost one. And I lost one because she left. But it wasn't because she was burnt out, it's because she got fired. So it was completely different. It was unrelated to the survey. It was unrelated to the work that we were doing with the pilot. It had to do with internal functionings at that clinic, and we lost her. So she took the baseline survey, and then she didn't take any more after that. So everyone attended the information sessions. In some cases, I had the mentor and the mentee together with me. So it was a great opportunity to do the introductions all at the same time. So that was actually really wonderful when we were able to do that. And then, of course, we pushed out the 30-day survey, and then 3 months, 6 months, and 9 months. And then we put it all together and did the analysis. So here's what we got. Here's the Crone Box, and I will talk about these in detail when I go through the analysis of this. So the Crone Box alpha for the emotional exhaustion was, there are, remember, 9 items for each, for emotional exhaustion, was 0.88. And then under depersonalization, there's 5 questions that relate to that, and it was 0.68. Remember what I said about the Crone Box? Below 70s are not as good. And personal accomplishment came in as 0.75. So that's what we had. And here's the demographics. Mostly female, mostly no kids, or even people at home that they were caring for, no parents. I actually asked if they had parents or kids at home. The majority of them had been in practice less than a year, which was great. I wasn't necessarily looking for that, but that actually was great. So I had mostly people that had less than a year experience. The other people that were more than a year experience, one had just over 2 years experience, and then another one had been in practice for just 1 year. They were mostly white. We had most of them actually below the age of 40. We had a couple of people that were in the 60 range, and then somebody who was in the 40s. And they were mostly married, which is interesting. So demographics are so fun because you never know what you're going to come up with, and this is what we got. So here's the Freeman Nova for emotional exhaustion. The numbers, I will explain that. The ranking is not the actual score of the Masslike burnout inventory. When you do the Freeman Nova, you rank the scores together. So for example, if you have people scoring, let's say 10 to 8, that's ranked as 1. And people that score 7 to 5, that's ranked as 2. So the Freeman Nova takes those rankings and does magic with them, and this is what they come out as. What we're looking for is significance in this, and the P in this particular case is too high. So we want a P, which is your significance score, to be below 0.05 in any really good survey. So we've got 0.268 for emotional exhaustion. For depersonalization, we have 0.99, and then for personal accomplishment, 0.82. So our statistical significance for these three, no good. I was like, God, what was that all about? So the ranking, though, is worth looking at. Let me just take you back to look at the ranking, where we sat at baseline 30 through 9 months. So you can look at the ranking scores and keep those in mind, because they didn't really change much. They didn't change significantly, we know that for a fact, but they actually didn't change much. There was a little bit of a dip in 30 to 3 months, and we see, again, the same thing on the mean rank here. You see that there isn't a lot of change in depersonalization. And then in personal accomplishment as well, not a lot of change in those numbers. Look at this, turnover. So we started with 2015. I actually added more data for you. 2015, so 2016 is when I shared earlier to 2017. Those were our numbers. And the first year turnover is that nice yellow line, yellow-orange line. The blue line is the kind of everybody's turnover, like you're leaving for retirement or you're leaving because you're moving to a new place. But the orange line is people leaving within the first year of being hired, okay? And this is significant when you look at the amount of change that we experienced in that first year after starting this pilot. So reliability was pretty darn good. I felt pretty good about that. At first, the statistician told Dr. Van and I, it's not significant, your study's not significant, and I was just heartbroken. It's like, all of this work, and what? I do a survey that means nothing, and in fact, the reliability was actually quite good, because he actually hadn't done the Crone Box. And then when we asked him to do that, it's like, oh, wait a minute. The Crone Box actually matches what's in the literature. Not only matches the literature, but it matches what MBI, Masslike, actually says should be their reliability for their study. So our study for emotional exhaustion was very reliable. Great news. Depersonalization, poor reliability. And we'll talk about maybe why that was. And the personal accomplishment, fair, right? Fair reliability at 0.75. But not too bad when you think about what the studies have shown us with Masslike in the past. The limitations for this study, tiny little n. We actually did there's a calculation you can do called power. And you can look at the power of your study to say, hey, if I can go back in time and add X amount of people to the study, what would it take to make it significant? Well, in my case, I would have needed 21 people to make the study significant. So gosh, so we had a small sample size, but great pilot, right? Something that we could actually test to see how it worked. We did have participants from 2 of the 5 medical groups, but boy, wouldn't it have been great if we had had representatives from all of the medical groups? That would have been kind of nice for variability. And then we may have had actually a little bit of a response bias. Because when I looked at the literature in Masslike, they made it very clear that you should not tell your participants that you're measuring their burnout. I mean, remember the questions? Like, why would they not figure that out? But whatever. We did have the conversations with people when I was actually doing informed consent. Why am I doing this study? What is the problem at Sutter Health? Why should I care, right? So I'm telling them, well, we're concerned about turnover. We're concerned about burnout. Here are the reasons that we want to do the study, and here's what the study's going to involve, and here are the types of questions you're going to get. So maybe we had a response bias because people are looking at the questions going, I'm not burned out, I'm good, I'm good, I'm good. And perhaps that affected our response to the depersonalization and personal accomplishment. The length of the study, maybe it was a little too short, maybe it was a little too long. Ideally, we would have done a year. And 12 months would have been in the bag. We would have known what kind of feeling people had at 1 year. I can tell you, though, based on the data I have, we've had no turnover, which is great news, because that was one of the data points that we wanted to measure. But these are limitations that we had to consider at the end of the study to say, OK, what happened to this study? So we didn't have statistical significance with our Freeman Novas. But really, what does the significance mean, right? I had to think about this after I came out of my funk, my own burnout. Came out of it and I said, all right, what's significance really mean, right? If I had measured and got a significant number with this study, it would have told me that my intervention of mentoring caused burnout. No, I don't want that. Or it could have been that it improved burnout. But what would that have meant? I would have had to have started with participants that are already burnt out so I could measure their improvement. What it said instead, right? What did my surveys actually show when I went through and looked at the results? I actually found that I had a pretty nice, happy group of people the entire year. So we had a little bit of a dip in people's feelings when you look at the survey results at around 3 months, which is classic. The 3 to 4 month period is really the kind of critical time within your first year for whether you're going to make it or you're not going to make it. And if you have support, you come out of that and you're good. But when you look at the numbers and those Freeman Nova rankings that I asked you to look at, you can see that there's very little change, right? So basically, my pilot group stayed pretty happy, not burned out the entire time. And that shows when you look at their actual survey results with their work-life surveys. So let's talk about this amazing turnover improvement. Oh my gosh, this I did not expect to be so good. I thought the graph would come down just slightly, but we actually are approaching almost national average, right? I told you 11% is the national average for first-year turnover. That's good. We want that. It would be great if it was lower, but we still have a problem with turnover here, just regular turnover being a little higher than national average, which is typically around 6 to 7%. So there are some things we can do to improve, but boy, this was a huge improvement that we were not expecting. Let me tell you a little bit about the mentors before I share a really cool thing that we found. As I said, they were all advanced practice clinicians. And that decision was supported in the literature. I wanted to do like with like, although I did have NPs with PAs and PAs with NPs, but I figured they're advanced practice clinicians. Let's just go with it. I had an interesting mix of years of service. So they ranged from 5, which is not a lot, but 5 years of service all the way to 25 plus. They were all female. There's not a lot of men right now in the medical group that are advanced practice clinicians. There's maybe a handful, I think 5. So I really had, when I asked the lead APCs for the names of people that they would consider mentors in their medical group, they only listed females. There really were no men listed because they're younger and newer that are men that are coming into the field. So they're not quite mentor material yet. And again, the types of practice that all the mentors came from were family practice, they were in urgent care and specialty medicine. here's what we found that was completely unexpected, totally threw me for a loop. The mentor joy of work was off the chart. Now, we did not intend to measure the mentors or even talk to the mentors. But when I talked to my steering committee at Sutter about this project, they asked me, well, what about the mentors? What about the mentors? And I said, what about the mentors? Who cares about the mentors? They said, you should go ask them. You should ask them questions like, what do they think about all of this? And I said, okay, maybe that's a good idea. I could do that. So we created 5 questions. We started with just 5 questions, and I did telephone interviews with all of them. Actually, I met a couple of them and had coffee with them. And I measured them again at the end of the study. So I did it right in the first month, and I did it right at the end of the last month that we did our survey. Here is the feedback. I'm telling you, goosebumps every time I read this. One of them rated it 5 out of 5. I would do this again. I wish I had somebody like this, like myself, supporting me when I was a nurse practitioner new in the field. I love doing this, and I am happy to do it again. And none of these people were paid. Another person, absolutely. I believe in this program, and I'm going to support this whatever it needs. I was like, wow. Another one, love it. I feel like I'm learning more by supporting them, the mentee. I didn't have this when I was starting. And then finally, already am committed to doing this again. I love it. Really feels like I'm contributing to somebody's future career. Wow, this was incredible. This was so inspiring for me that we decided that we needed to do a study on this next year. So Dr. Van and I have plans to do a qualitative on the mentors, because this was incredible. We did not expect the mentors to just love this job. I did not expect this. This is a little extra. Some of them took their mentees to coffee. Some of them took them to lunch. Some of them took them to dinner. Like, I didn't ask them to do that. This is something that just naturally came out of the process. And they ended up developing these classically beautiful relationships where they now are they consider themselves friends. They're just friends. And when any of them have a question, they just reach out and talk to each other. And it's the mentor and the mentee are now equal in their relationship. So it's not that the mentee is constantly asking the mentor for things. The mentor actually recognizes that the mentee knows and does things that are very helpful to their practice as well. And what a great thing to have as an outcome for the study that I never expected to happen. So the implications, let's just talk about this from Sutter's standpoint. Burnout continues to be a concern, and the problem is we don't know what's going on with our advanced practice clinicians because there's just not a lot of studies out there, but I'm going to bet dollars to donuts that it probably mirrors what's going on with our physician colleagues, right? How could it not? We're doing the same work. So we need to be more aware of what's going on with our advanced practice clinicians, the turnover, the reasons for leaving, people's health. Are we having suicides? Nobody knows. Nobody's actually collecting that data on advanced practice clinicians. We should know that. And turnover is expensive. A lot of us don't really think about the cost of when somebody leaves. We're just kind of like, oh, it's really sad. I'm so sorry you're leaving. But all of the ripple effect that was upstream of that person coming into the job is lost when they walk out the door. All of the recruitment time, all of the training time that we've given to that person, all of the people that are teaching them how to use Epic, all of the people that are answering the phone when they call the help desk, all of those people helping these new clinicians be successful is all lost when they leave. Not only that, patients can't get appointments. So all of those patients now lose access when we lose a provider. And all of those extra appointments go on to the remaining providers that are in the office, which probably increases their burnout, right? Their stress and anxiety. Market competition is a very real thing right now. We are having trouble finding physicians, but we also are having trouble finding advanced practice clinicians. There's just not enough providers out there. You know, there's always the perfect person you want to hire that has 10 years experience and they can just walk into the job. But those people are like unicorns. They really are not out there anymore looking for jobs. And the people that job hop are typically not the people you want to hire, right? So it's difficult to find people. And I know that one of the healthcare organizations in Northern California has decided to no longer spend money recruiting. They're gonna focus all of their time and effort on trying to steal people from other healthcare organizations. Competition is just gonna heat up because there's not enough people. And replacement costs, as I mentioned, are very expensive. And of course, the training is so expensive when you bring in a new physician, APC, or a nurse. They have literature that actually says that losing a physician costs about $1 million. I mean, that's an organization, that's a one-time cost to an organization, $1 million loss with a physician leaving. But advanced practice clinicians, we don't really have the data. We're making assumptions about what the loss is. Maybe it's $500,000, maybe it's $250,000, but regardless, it's still in the hundreds of thousands of dollars whenever you lose an advanced practice clinician from an organization. So this is top of mind for the employers as people are leaving our organizations. For employees, I think it's important to know that reducing stress when you enter a new job is really important because that's how you're going to be successful when you're a new employee. You have an increased self-confidence, therefore you can be more successful as a provider. You actually deliver better care when you're more self-confident and supported as a provider in a healthcare organization. That reduction of emotional exhaustion and that the sense of burnout in the mentee is critical. And the retention, right? Not only for the mentee not leaving the organization, but the retention for our mentors who have this joy of work supporting the mentees is also really important for our employees. So the system basically has agreed that we will continue this pilot and turn it into a massive study for the entire year of 2020. So we're going to include every medical group, every APC that gets hired, regardless of years of service. So whether you have been a nurse practitioner for 10 years or a PA for 15 does not matter. Everyone's all in. Because what we know now is that actually burnout probably affects everybody that's new to their job. It doesn't matter whether you're a new nurse practitioner or you're not. So we're going to include everybody in the study so we can really diversify the results and look at how people are feeling when they're an advanced practice clinician in Sutter Health. We're going to create and provide a pool of resources for our mentors that we did not have before. Because throughout the year, we were getting questions and requests for things like a mentor manual or even agendas. Like, give me an agenda that I can use with my mentee every single time we meet. Like, we could easily do that. There's a lot of great resources. They really wanted framework to help guide them on how to be a mentor. And the mentees need this as well, because the mentees really are the ones that should be driving what their needs are. So it's not the mentor telling them, but it's the mentee saying, hey, I need help with this. And then, of course, data tracking, so we can actually track the retention of the mentors and the mentees in the coming year. So next steps. Submit for publication. Thank you, Dr. Van. And I've been accepted to do this presentation to 2 state conferences already. I'll be doing a presentation at the California Association for Nurse Practitioners Conference next year, and then the Association for California Nurse Leaders. Looking forward to that. So, in closing, mentoring is not an extracurricular activity. It is vital for us to cultivate an enriching and inclusive community. So I want to thank everybody, my family, everybody who's come today to listen to this presentation, and I am here for questions. Thank you.
Actually, I have a question. Here, this is Qinghua Wang. Yeah, so it seems to me nationally, okay, this is California for sure, that many of these burned out nurses, they quit, they leave the hospitals, and then they join the teaching, the faculty. at community colleges.
Ah,
Right. Community colleges, 4-year, and institutions like us. Um, so, what do you think this kind of prognostic, situation of these burnout nurses turning to faculty, the impact of that is on our faculty?
that is an excellent question. And that actually is not something I actually would necessarily know the answer to yet. Most of the people, because we don't do exit surveys, so we don't understand why people are leaving, first of all, and second of all, we don't know where people are going. And when I was hiring people, when I was at the Medical Foundation, I would ask them, well, why did you leave your last organization? And just like the literature says, 100% of them would say, because I didn't like my boss, I didn't like my supervisor, who I reported to. Nobody ever told me they left their job because of money, interestingly. But I find that most people leave healthcare. They don't stay in the role of being a clinician at all, and I don't find that they're necessarily teaching either. In fact, the only example that I can share is clinicians that have gone to nursing, pre-licensure teaching, as opposed to being a advanced practice clinician instructor. So they go to pre-licensure teaching, or I actually know of one nurse practitioner who quit for a variety of reasons, but I know it was because of burnout, and she became a nurse again. So she's working as an RN. And I always worry about her because I see that she continues to struggle. She's a new mom and still hasn't really resolved that sense of burnout that she had as a nurse practitioner. And she's in the same organization, which is interesting. So we didn't lose her, but we did lose her as a provider. She became an RN. But I think that's worth further study.
Yeah, there might be a research topic there.
Yep, absolutely.
When I was the provost and I attended some national meetings, talking to the other provosts, and almost all of them have issues regarding their nursing school.
Right.
I mean, it seems like it's all the nursing programs are having all these appeals, and I'm just wondering about that. Yeah.
Yep, absolutely, yeah. Yeah, and I would suggest that if we worry about that here at Samuel Merritt, that we might consider mentoring for faculty. So that might be a way to mitigate that.
Yeah, I think though, a great idea, mentoring. However, I think we need to identify the root cause for burnout, right?
Right.
To resolve that issue so that before they turn into a burnout person.
Right.
Thank you.
Hi, Fred Baldini. I really enjoyed your talk. Thank you so much. I do agree. There's a application here in higher education, and I've been involved with mentoring programs in my prior life, and I see the benefit. I think there's a connection there. I'm glad you're going to the bigger study. I think there were some issues there that you pointed out that might have limited that, and that power number is helpful to encouraging. Right. I'd also encourage you, though, to the group that you started with, it's not very small, but it would be interesting to follow them over time as well. So as you build in these new groups, following long-term,
right.
5 years, 10 years down the road, looking for long-term impact, I think that would be useful as well.
That's a great point, actually, because my husband's comment about how can you be burned out after 1 year is a good point. And actually, there is not a lot of literature to support longer-term studies to see how people are feeling. So that is, because they're within Sutter, it's something we could consider doing. And I know that the longest studies I've seen were actually in physicians. They actually did studies in residents. And the burnout is amazing with medical residents in second year and into third year. But after that, they just fall off and they never follow up with them. So I always wondered what happened to them after the third year.
Well, with that newer, bigger group as well, you're going to really have an opportunity for a longitudinal look at that.
Right. Yeah, great idea. Thank you.
I just want to let all of you know that Yassine is in the back and he's tweeting. He's been tweeting the entire.
Thank you.
So thank you very, very much. Dr. Villanueva, did you have a question?
Mm-hmm. And then Sherry has a question here.
Okay. I just have a quick question. So did you consider any external factors as, that could contribute to
Burnout?
Burnout, like, fires and all that kind of stuff that
Oh, yeah, very good question. And, because the fire happened, I'm trying to remember timing of that exactly. The fire happened before we did the survey. So everyone was measured after that fire, and that did cause, in the community, it's caused a lot of stress across the organization. One thing Sutter does is they support employees with an internal employee support program. And I have no idea whether any of the clinicians took advantage of that. I think clinicians feel less inclined to do that than the staff nurses or the medical assistants would feel more comfortable approaching a therapist, to talk about their stress. But yeah, it didn't impact that timeline. But interestingly, we just had another fire, and I have already stopped measuring, so I missed the fires. Thank God. But that is a really good point. I didn't think about an external factor, but there wasn't anything going on at the time I was measuring them. A good question.
like time of year.
Yep.
Because, holidays.
Yep. Yeah, holidays as well. That's a really good point. So doing it over a year would be more helpful. Yeah.
Thank you, Surani.
Yes.
And congratulations. And for
Thank
those who haven't worked with Surani before, she's always like this in terms of her energy. So it's amazing. Dr. Wong and Dr. Baldini covered a lot of the academic practice partnership things that I think we can do. So I'm going to choose another question. And I guess it has to do with the effect of external factors as well. The fact that you actually educated more of the office workers and the environment about nurse practitioners, what kind of impact do you think that had? Because I think that's a huge part of, right, helping our practitioners who enter the field. What exactly do you do? So I wondered if you had thoughts about that.
That's a really good point, because I didn't necessarily go out and teach all of the offices. I only taught the offices that we had participants in. So the staff at least would understand what's going on. They understood that we were doing a mentoring study. Whether they remembered it or not, I have no idea. But I think that is a really good issue to consider, because we have a lack of understanding about the role of a nurse practitioner or a physician assistant or even a midwife, honestly. Nurse anesthetists, people have no clue, right? They have no clue.
They
Yes.
have no clue what we do.
And so I think that doing more education is critical. And one of the things that Sutter Health has done in the past 2 years, it is my role. I actually have led a system-wide initiative that focuses on the experience of the advanced practice clinician within Sutter Health. So I've done a number of things with a very large steering committee to move change through the organization. And some of that is just marketing advanced practice clinicians so everybody understands who they are. Also putting me in front of the providers in different settings, whether they're the symposiums, the large symposium. I've been at the management symposium, which is 3,000 managers in Sutter Health attend that, and they've heard and seen an advanced practice clinician on stage, so that's been very helpful. And hearing stories about what PAs do, what NPs do, also very helpful. So really, we're talking about culture change. And culture is not something you can just change with an initiative, and we recognize that. But it is something that can change over time, and we're starting to see improvements in responses to suggestions that advanced practice clinicians might have a bigger role in the organization. And that I can personally attest to in my experience with the physician APC symposium that we've had with Sutter Health. The reaction from the crowd has been dramatically different from the first year I did it to this last year, dramatically. I actually had physicians stand up and challenge me, yelling in the breakout session as I was presenting, talking about the fact that we're losing physicians and we don't have enough to hire, challenging me on the data. It was amazing. In that first year, I was just completely struck by how anxious and clearly burnt out the entire team is in healthcare with that reaction. Instead of saying, hey, let me just listen to what she has to say, challenging to say, no, that's not the problem. It goes back to what is causing this issue, right? And so this year, completely different, literally coming in and saying, hey, can I reach out to you and ask you questions about how I bring in my nurse practitioner to be more successful in the office? Big differences. So just personally, I can share that that has happened in the organization.
That's congratulations,
Thank
Surani.
you. Thank you.
Wonderful presentation. That I had two questions, but that one is a good segue. Your last comment is a good segue to what I was going to ask, which is whether you're thinking as you broaden it about looking at the impacts on the broader practice group. You were focusing on mentees.
Right.
You got kind of the bonus of what the mentors told
right.
you. But for me, if you've got people burned out in a close working group like that, it affects everybody in the group.
Yep.
And so for me, one of the questions is how might you wrap your mind around and gather data on what the impact of sustaining people and creating friendships within the group and mentoring
Right.
relationships within the group has on the whole team.
Right. One thing I didn't share is that the medical groups, 5 of them now, all have mentoring programs. And whenever I present this in front of the medical groups, I share with them that, in fact, a lot of the data comes from the physician and nursing world, because there really aren't that many studies for advanced practice clinicians. And that we know that mentoring supports physicians to be more successful. So 5 medical groups in Sutter Health have now mentoring programs, which we've never had before. So I've suggested that all of the work that I have done, you can just translate it to physicians just as easily. And one of the physicians in the Santa Rosa group reached out to me this last year because she was setting up the mentoring program for the physicians, because she herself had an awful experience. The fact that she's even still there is an amazing thing. And so she took the survey elements and put them into practice for the physicians. And I reminded her that we were doing this for advanced practice as well. She says, yes, of course. So they all have a pilot or a mentoring program in every medical group now, which was a big change.
But I think the other question is, how does it affect the non-clinicians?
Absolutely.
In the environment.
Absolutely.
And that web that weaves it together. So I had one other question.
Yeah.
When you were showing your graph of the turnover, there was this jump from like 6 and 4%
Right.
to 18.
Right.
What was happening there?
So interestingly, numbers were very low because we didn't used to have a lot of nurse practitioners. You know, I mean, really, the organization in the last couple of years has hired, I mean, we are hiring on a continual basis. Every month they're bringing in new nurse practitioners and PAs into the organization. So that number increasing was more related to the numbers of people that are being hired, but so many were turning over. And one of the reasons that the turnover was so bad was because in one of the medical groups, they were having the nurse practitioners essentially be the helpers of the doctors. They weren't seeing patients. They were on the computer only. So they would come in, I'm getting my first new job, yay, I'm so excited to work for Sutter, this is gonna be great. They show up to their job and they say, hey, you're gonna be on the computer today. Oh, and you're gonna be on the computer tomorrow. And we need you to cover the next week as well because Dr. X is out of the office, so you're gonna cover all of his stuff too. So they're not seeing patients at all. So within a couple of months, most of them are like, I'm looking for another job. And they were out of there. And that was the group that was seeing 25% plus turnover. They were continually losing people. So they'd train them, they'd stay for a couple of months, and off they went. And that's why you saw that number go up, because they were hiring so many of them. So it's kind of a dual effect, but boy, bad news. So we knew that was not going to work. So yeah, big problem.
Okay, Surani, as your
Yes.
mentor, I'm still monitoring, and you've been speaking for 90 minutes. But I'd be remiss if I didn't ask if any of your family members or Sutter colleagues have a question.
Hey, so in conducting a larger study, do you think it would be valuable to have participants, APCs, who haven't received mentoring at all, to compare to see if there's a strong benefit?
Right, so that's a really good question. So we had talked about that. The problem is that every medical group has a mentoring program, so there isn't a cohort to compare against. I had thought about that for this group, and it was becoming too big. We didn't have enough people to even enroll. So at that point I said, I'm not going to worry about a control group. I'm just going to measure these people and give them mentoring and see what it looks like. You know, basically just measure their burnout. With the assumption that my North Star on that was the turnover, right? Are they going to stay with the organization, or are we going to lose them within a year? So that was my kind of telling if that was going to be successful or not. There is one more group that I could possibly use, and that's in the hospital. The hospitals right now are hiring a lot of nurse practitioners and PAs, mostly NPs, to take care of patients in the hospital and in the hospitalists and intensivist services. And that group has no mentoring, and they're struggling. So the physician and operations leads in the hospitals are asking me to set up mentoring in the hospitals. So potentially I measure them before I do that and then use that as a compare group. So it's a good question, though. I thought about it. Yeah, in the back.
Yeah, so it's interesting. I just think your study's so interesting that you really were looking to understand how mentoring, right, could impact retention on the mentees.
Right.
It would be interesting if, as you go forward, perhaps using the same instrument you used on the mentees, on the mentors.
Yes.
Right?
That's the intention.
Great. Yeah, because, I mean, clearly they enjoyed the heck out of it,
Yep.
right?
Absolutely.
And the other thing that I think is a smart, where you're going with it, is standardizing materials, because the quality of the mentor,
Right.
The aptitude of the mentor certainly has an impact, I would think, on the mentee.
Absolutely. And there are some organizations that actually have you apply to be a mentor. So you have to pass a series of reviews before they'll accept you to be a mentor. I was simply asking as a subjective from the lead APC, who would you consider to be a mentor in your organization? Since then, we've now actually created a job description for a mentor. So there are criteria that people would meet in order to be considered a mentor by the organization, because the medical groups are now thinking about reimbursing for that role. It's not much money, but it's a little bit of money on top of what they already get paid to be recognized as a mentor by their organization, and that's pretty cool. So, and they're doing that for the physicians as well. So they asked us to develop a job description for the mentors. So we did that to capture that criteria.
We have, oh, go ahead.
Follow up to Al's question. So there's a formal training. As a follow-up to Al's question, is there formal training provided to the mentors as well? And is there a need to develop programs around how to be a successful mentor or how to be an effective mentor?
Right, so that was a point for us in the team to talk about whether we could actually do that. What does that look like? It's very hard to train clinicians. They don't have time. They don't want to come to things in the evening because they're tired. They don't want to give up their weekends because they have families. And so the idea is that how can we get stuff in front of them that's going to be edible and fast and meaningful. So we actually, in a different part of the work that I'm doing for the system, created training videos for preceptors. So very much all of the tenets that you would have for mentoring. Exactly the same types of things. How to talk to people, how to be supportive, et cetera. So we theoretically could take those, basically they're 3-minute videos. There's 23 of them. We could take all of those and turn those into tools to use for the mentors. They're viewable on your phone. You can watch them on YouTube very easily. And the medical groups are starting to ask me for those videos. So I've been thinking about how I would kind of retitle those as tools to train. But essentially, all that I offered to begin with was Harvard Business Review articles about being a mentor and a mentee. And then also, I had a book called The 1-Minute Mentor. Very fast read. You could literally read it in 20 minutes. Or you could just read a chapter at a time, which is just a couple of minutes. And it just gives you the essence of a topic. So you could take it and think about it. So you're right, we definitely want to create a more standard process for how we deliver information to the mentors. And combined with the job description, I think will be very helpful to create a little bit more of a standardized experience for the mentee. But again, what mentees need is different, right? Every mentee needs something slightly different, so.
I just want to interject a comment here. It's the president's cabinet. President Ching and her cabinet has taken over. So I have no power, but anyway.
I actually have another question. I have another
I
question.
love it. I love it. President Ching has a comment, and then Patrick, the spouse, has a comment,
Okay.
and then I have a big announcement.
All right, thank you.
Oh, good. I'm excited. So it seems like it's everybody recognized the fact that a significant population of the APCs, the nurses, physicians that are burned out, right? So we are in the process of developing an academic master plan, meaning
Right.
a blueprint for all of the academic programs existing and in the future. So I'm just wondering whether it's good for, since we're an educational institution, to develop a program that teaches mindfulness, all of these things, for the APCs and physicians and such, and our nursing students. I mean, I think it would be a fantastic thing. I'm dreaming, of course.
Oh, it's a reality.
Actually, that is a reality, and so they're saying also that while mindfulness is very important, learning how to create space in your day and around yourself while you're in a very busy, stressful work life is important. They're also saying that that is not enough. They're saying that mentoring probably is the kind of cherry on top to help the entire program be successful. So mentoring really has come out in a number of studies just in the past year, suggesting that the mindfulness training and having yoga at lunch may not be enough. We actually need to consider doing more to maintain the support for the teams of whoever is doing the work.
It could be a program, a combination of those.
right.
I think we have some expertise here.
Yes, absolutely.
Paulina.
Exactly. All right, Patrick.
Patrick, you're going to close this up before my
Well, who
big
knew that I was
announcement.
going to be speaking today, except to say there's no way that I can really follow in
I
Surani.
know, give him a mic and look what happens.
It's a tough act to follow.
Yes.
Everybody knows that here. I'll just put this in context, of course. First of all, I'm going to say that I think I know what the solution is to burnout. And that is for everybody to study Surani. Because really the context that she's been working in has been for her to be working, let's see, how many jobs do you have exactly?
Yeah.
She works, of course, for Sutter. She is a practicing nurse practitioner in a clinic in West Sonoma County. She takes care of me. She's on multiple boards locally, 7?
Yeah.
So she is a very, very busy woman, in addition to doing her DNP here. So that's I'm not sure how many full-time jobs she has. And yet she does this with pleasure and energy, and she's still happy to see me when I come home. In other words, there's no hallmark of burnout in her at all.
Yeah.
Incredible the energy that she brings to her. And I also would like to say that some of those numbers that we saw, low rates of burnout at the beginning and then increase and spiking in 2017 and coming back down again, are probably a consequence of Surani because we studied Santa Rosa, and she used to work at Santa Rosa. And I'm sure as she was working as a, what were you anyway?
Executive Director of Operations.
Director of Operations, right. She was highly involved with many of the people in Santa Rosa, and people looked up to her, as we do right now. And I think she was a mentor for many people there. And she was successful in single-handedly bringing up a lot of people in leadership, instructing them, and probably was instrumental in keeping those numbers down in that one location. And she did leave under circumstances which I would say would burn me out. And in 2017, right? 2016 to 2016, right? So maybe that's why the numbers came up.
I should put that on my limitations.
I would like to do that. But anyway, Surani, you are an inspiration to all of us. But
Thank you.
You are my mentor. You're a mentor to me. And, if only we could have many, many more of you, I think we could take it.
Well, thank you. Thank you, honey. Thank you.
Ronnie, would you come on down? Marianne, would you like to say anything? You're good? Okay. Surani, besides having 24 jobs, is also extremely humble. She seamlessly talked about this project, yet she left out the fact that she was a major lobbyist to even get this off the ground. along the way, there were mountains, no molehills,
Yeah.
just mountains. And she climbed them eloquently, effectively, and we see what she's done. And so it is with just privilege and humbly that I present you to President Ching and her cabinet, to your loving family and friends, to your clinical partners, to the administration and your colleagues in the School of Nursing, as Dr. Surani Kwan.
Wow. Thank you. Thank you very much. Thank you.
Okay, so I do have an announcement, and I'd like, I will make it, but it's, I'm just the face of the President's Council and the school's administration in making this announcement. So if you would just
Sure.
allow me to do this. Dr. Kwan and audience, I'd like to talk to you about an award that we give. And each year, a graduating DNP student is chosen for the award of Outstanding DNP Student. The student chosen for this award is distinguished among all of the students in his or her class. The award recipient is chosen by the judgment of the doctoral faculty as the doctoral student who best exemplifies the School of Nursing's mission to promote health and well-being across diverse populations and communities, and the school's commitment to educating leaders to transform practice. The recipient demonstrated excellence and innovation in the conceptualization, implementation, and analysis of their project, and extraordinary leadership and service to others in their practice and community. Above all, the recipient's project has the most potential for ongoing impact on nursing practice and the Sutter healthcare system. This year's Outstanding DNP Student Award, that will also be officially given at commencement on December the 11th, 2019, goes to Dr. Hare Kwan.
Wow. Oh my God. That's amazing. Totally
She had
unexpected.
no idea.
No.
So instead
Wow.
of taking your breath away
Yeah.
at commencement, we did it here.
Nice.
Among
Thank you
this
very
intimate
much.
group. Would
Thank
you
you.
like to say something?
I've talked enough. Thank you very much. I appreciate the support. It has been an amazing journey, and I could not have done this without everyone in the organization, Sutter, Samuel Merritt, my family and my friends, my clinical workplace. Oh my gosh, so much support. Thank you very much.
So on that high note, we are going to close this formal session, but we ask you to eat, drink, and be merry. And you take this and levitate back to Santa Rosa. Okay. All right. Thank you guys for coming.